Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
So picture this. You're about 2 hours into what was supposed to be just a routine left hemicolectomy.
Oh, right. Famous last words.
Exactly right. So you've taken down the splenic flexure, you've completely mobilized the descending colon, the tumor is out, and you're getting ready to create your anastomosis.
Yeah, you're feeling good about it.
Right. But then you look closely at the proximal bowel edge, and it's looking just a little bit, well, dusky.
Oh, man. The worst feeling.
It really is. The pulse in the mesentery feels thready, or maybe it's just absent entirely, and that is the exact moment every colorectal surgeon dreads,
Yeah, because suddenly the anatomy shifts from this, neat textbook diagram into a literal high-stakes crisis of perfusion.
Exactly.
Yeah.
So today we are speaking directly to you, the surgeons and doctors out there in the trenches. We're doing a deep dive into the anatomy behind that exact moment, and, more importantly, how to prevent it. But before we get into the weeds, I do need to lay down our mandatory disclaimer.
Right, gotta do the housekeeping.
Yeah. So just a reminder, this content is for reference only, and you must follow your local guidelines in clinical practice. Always check your local protocols.
Definitely. But, getting back to that dusky bowel edge, that's really the ultimate consequence of failing to respect the underlying blueprint of the body.
Right.
Because today we are looking at the large bowel not just as a static tube, but as this incredibly unforgiving landscape.
I mean, we're talking about the terminal 1 to 1.5 meters of the GI tract here.
Exactly, stretching all the way from the ileocecal junction right down to the anal canal. And as a surgeon, you're constantly dealing with this transition from intraperitoneal mobility to extraperitoneal fixation.
And at the same time, you're trying to balance the absolute oncologic requirement to strip out lymph nodes with the physiological requirement to actually leave enough blood supply to keep the tissue alive.
Right, which is a massive balancing act.
It is. And as surgeons, we rely so heavily on visual cues to navigate that landscape. We use surface landmarks.
Yeah, the classic trio, right. Taenia coli, haustra, and the appendices epipleia.
Right. And I always think of the Taenia coli as like highway lane markers, They reliably lead you straight to the base of the appendix.
They do. They merge right at the rectosigmoid junction, too.
But, okay, let's unpack this for a second.
Right.
Because besides just finding the appendix, why do these physical features actually matter when you're in the middle of, say, a really messy adhesiolysis?
Well, because when a patient presents with a massive, large bowel obstruction, or maybe severe inflammatory bowel disease, those classic landmarks, they completely deceive you.
Oh, yeah, everything just gets distorted.
Exactly. We learned that the taniae converge, but functionally, because those longitudinal muscle bands are actually shorter than the colon itself, they act like a physiological drawstring.
Right, which creates the haustra, the little pouches.
Yeah, but when the bowel massively dilates from an obstruction, that drawstring mechanism just fails entirely.
The haustra just flatten out.
Completely. You lose that classic segmented look. And suddenly, the transverse colon looks alarmingly like a massively dilated loop of small bowel.
Which is terrifying if you're operating laparoscopically or robotically, right?
Yeah.
Your field of view is so tight.
Oh, it's incredibly dangerous. Relying solely on haustrations in that scenario is a trap. You got to trace the taniae back to their source or actively look for the appendices epiploicae.
I want to push on those fat tags for a second. The appendices epiploicae. Because we encounter them constantly, and they are notorious clinical tricksters.
Oh, they really are.
Imagine a patient comes into the ER, right? Highly localized left lower quadrant pain. White count is up.
Sounds like diverticulitis.
Exactly. It looks like acute diverticulitis on the scan. Maybe it's slightly equivocal, but you take them to the OR, and it turns out to be an infarcted fat tag that just twisted on its own pedicle.
Yep. Torsion of the epiploic appendage mimics an acute abdomen perfectly.
So in that scenario, when you're staring at a necrotic appendage that looks like a major perforation, what is the actual surgical threshold? What do you do?
You just ligate it at the base and leave the colon alone.
Really? Just leave the bowel?
Yeah. I mean, the temptation, especially for a junior surgeon staring at this angry, inflamed mass stuck to the sidewall, is to assume the bowel wall itself is compromised.
Right. You think you need to do a resection.
Exactly. But unless the base of that fat tag has caused full thickness necrosis of the colonic wall, which, is exceedingly rare, simple ligation is curative.
Wow. So recognizing the difference between primary colonic ischemia and just an isolated epiplug infarction, that literally saves the patient from a totally unnecessary colectomy.
And a potential stoma.
Yeah, exactly. But getting to that pathology or safely removing it when you actually do need a resection, that requires this total obsession with planes.
Absolutely.
And we tell residents all the time, right, just follow the avascular plane when you're mobilizing the right or left colon.
Just follow the plane. It sounds so easy.
It does. But realistically, when you're staring at a monitor and the field has already been stained with blood from prior dissection, the idea of a pure avascular line feels like an academic myth.
Yeah, it does.
So is Tolt's fascia really just a line we follow? Or is it something more? We call them avascular, but how does understanding these sticky versus mobile parts actually change the surgical approach?
Well, what's fascinating here is that it's a strict embryological boundary. Treating it as just a line is exactly where surgeons get into trouble.
How so?
Because Tolt's fascia is the exact plane where the primitive dorsal mesentery fused with the posterior abdominal wall during, embryonic rotation.
Right, so it's two layers mashed together.
Exactly. It's a fusion of two distinct mesothelial layers, which means there are absolutely no bridging vessels crossing it.
Which is why we exploit it for a lateral to medial or medial to lateral mobilization.
Yeah, usually via a medial to lateral sweep. When you enter the correct plane, you see this very specific gossamer-like yellow-white interface.
Oh, I love seeing that, the angel hair.
Right. The areolar tissue should literally just separate with gentle pneumatic dissection or just careful blunt sweeps.
But okay, what about when it doesn't separate easily? Like when you find yourself actually having to use energy to cut through thick tissue just to mobilize the descending colon?
Oh, that's your immediate warning sign. That means you've breached the envelope and you're digging into the retroperitoneum itself.
And that's exactly how the ureter gets injured.
Exactly. The ureter and the gonadal vessels, they belong to the retroperitoneum. If you stay on the correct side of Tolt's fascia, lifting the colonic mesentery anteriorly, those structures naturally just fall away posteriorly.
Right. Out of harm's way.
But the moment you see raw bleeding muscle fibers of the psoas, or you get some unexpected venous bleeding,
Go deep.
you violated the boundary, you have to stop, back out, reestablish your orientation, and find that avascular fusion layer again.
So respecting these embryologic planes really is the secret to a bloodless dissection.
It is.
Now, that medial to lateral approach is beautiful when it works. But the real technical challenge, at least for me, is taking down the flexures, especially the splenic flexure.
Absolutely.
Because you can get the most bloodless mobilization of the descending colon using Tolt's fascia, but if you put too much traction on the splenocolic ligament without actually dividing it sharply, you're going to tear the splenic capsule.
The spleen penalty.
The spleen penalty, that happens so fast.
It really does. The splenic flexure is anchored high and deep right under the ribs. And the key is understanding that the attachments here, the splenocolic and phrenincolic ligaments, they're true suspensory ligaments.
Meaning they hold weight.
Exactly. They don't contain major vascular trunks, but they are dense. If you just pull the colon inferior-medially, just hoping it'll yield.
The capsule of the spleen is going to give way before the ligament does.
Yep. And suddenly you turn a highly controlled oncologic operation into an acute hemorrhagic crisis.
Which nobody wants. You have to use countertraction on the omentum and dissect sharply right on the bowel wall.
Right.
And, we mobilize that flexure to ensure a tension-free anastomosis deep in the pelvis. But dropping the colon down to the rectum isn't just about physical reach, is it?
No, not at all.
Because it brings us right back to that dusky bowel edge we talked about at the very beginning.
Yeah.
You can get the colon all the way down to the pelvic floor, but if you severed its blood supply to do it...
You've completely failed.
Right.
Which introduces the whole plumbing issue, right? The fundamental vascular divide of the colon.
The two embryological territories.
Exactly. You are constantly navigating between the midgut, which is supplied by the Superior Mesenteric Artery, the SMA.
That's the cacum up to the proximal two-thirds of the transverse colon, right?
Yep. And then you have the hindgut, supplied by the Inferior Mesenteric Artery, the IMA. In any major colonic resection, you have to definitively ligate one of these primary trunks or their main branches.
Well, here's where it gets really interesting, right? Let's talk about the left side, the IMA territory.
Yeah.
Because this is where the most intense surgical debates happen.
Oh, the high tie versus low tie debate.
Yes. I have always struggled with the dogmatic approach here for cancer resections. When we do a sigmoid colectomy for cancer, we're taught to take the IMA right at its root, to maximize the lymph node harvest.
Right, the classic high tie.
But sacrificing the left colic artery, which comes off the IMA, it just seems like you're begging for proximal anastomotic ischemia. I mean, is the oncologic benefit of a high tie actually worth the physiological risk to the descending colon?
It is literally the defining controversy in colorectal surgery.
I'm glad I'm not the only one.
No, it's a massive debate. So a high tie involves ligating the IMA flush with the aorta. You're sweeping the entire lymphatic drainage basin, including the apical nodes right at the origin, entirely en bloc.
Which is great for cancer clearance.
Right. The survival data historically supported clearing out that central reservoir for node-positive disease. But doing so means the descending colon is now entirely reliant on collateral flow coming all the way from the middle colic artery.
Right. I always think of the SMA and the IMA like two distinct rival power grids supplying this massive city.
That's a great analogy.
Normally, they just operate their own districts, but they are connected at the border by a single, honestly somewhat unreliable extension cord running along the edge of the colon.
The marginal artery of Drummond.
Exactly. So if you perform a high tie, you cut the main power from the IMA grid, and suddenly the entire left side of the colon has to draw all its voltage through that single extension cord from the SMA grid.
And as you said, that extension cord is notoriously flawed.
It is.
There are watershed zones where the anastomotic connections are incredibly weak or sometimes completely absent.
Like Griffith's point.
Exactly. Griffith's point at the splenic flexure. It's the literal junction between the SMA and IMA systems. And up to 20% of patients have a discontinuous marginal artery at this exact location.
20%. That's huge.
It's massive. And then you've got Sudek's point down at the rectosigmoid junction, where the last sigmoid branch meets the superior rectal artery.
So what does this all mean for the surgeon standing at the table right about to create an anastomosis in these areas? Because doing a low tie, where you ligate the IMA below the takeoff of the left colic artery, that sounds incredibly appealing.
It does, right?
Yeah. You preserve the left colic, you maintain direct arterial pressure to the descending colon, and your anastomosis is functionally bulletproof. But aren't you leaving apical lymph nodes behind?
You are. And this raises an important question about oncologic compromise. That's why the modern approach in a lot of high-volume centers is a compromise. To perform a low tie to preserve the left colic artery and the perfusion, right? But you still dissect out the tissue around the root of the IMA to actually harvest those apical nodes.
Oh, wow. So you're skeletizing the vessels.
Exactly. It's technically way more demanding, especially if you're doing it laparoscopically or robotically, because you can't just fire a stapler across the main trunk.
Right. You have to be meticulous.
But it drastically reduces the risk of a catastrophic leak at your anastomosis. Assessing that marginal flow is just non-negotiable.
Let's layer in a clinical complication here just to make it fun.
Okay, let's hear it.
You're operating on a 75-year-old patient. They have colon cancer, but you look at their chart, and they had an open abdominal aortic aneurysm repair like 10 years ago.
Oh, boy. That changes the entire landscape.
Right.
Because during an open AAA repair, vascular surgeons almost universally ligate the IMA as they replace the aorta with a synthetic graft.
Right. So what does that mean for our power grid?
It means for the last decade, this patient's entire left colon and upper rectum have been surviving purely on collateral flow through that extension cord from the SMA.
Their primary grid was shut down years ago.
Exactly. So if you go in to do a sigmoid resection and you don't realize their IMA is already gone and you accidentally disrupt the marginal artery, or you mess with Sudek's point down by the rectosigmoid junction,
You're cutting the only cord left.
you will plunge the entire descending colon and rectum into irreversible ischemia. There's no backup grid left to turn on.
That is terrifying.
It is. And that's why assessing marginal flow intraoperatively is no longer just about, looking for a dusky bowel edge or feeling for a pulse in a fat-laden mesentery.
Because subjective visual assessment is notoriously inaccurate, even for really experienced surgeons.
100%.
And this is where indocyanine green, or ICG fluorescence, has completely changed the game.
It's a lifesaver.
You literally inject the dye intravenously, you switch your robotic or laparoscopic camera to the near infrared spectrum, and you just watch the tissue literally light up.
Exactly. ICG angiography gives you an objective, real-time map of the microperfusion. It shows you exactly where the watershed zone fails.
So if you inject ICG and the proximal edge of your planned anastomosis just remains dark, while the tissue, like 5 centimeters upstream, lights up neon green.
Your decision is made for you.
You have to extend your resection proximally until you reach brightly fluorescent, perfectly perfused tissue.
Because you cannot staple dead tissue and expect it to heal.
Never. You're just asking for a leak. Now, we spend so much mental energy obsessing over the arterial supply, keeping the tissue alive. But oncologically, and we touched on this, it's the venous and lymphatic drainage, the cleanup crew, the exit routes, that actually dictate whether the patient survives their cancer long term.
Oh, absolutely. Because tumors don't just spread through direct invasion, right? They shed cells into the venous and lymphatic outflow tracts.
Right.
And the veins and lymphatics basically follow the exact same roads back to the city center. The venous drainage parallels the arteries. So the right colonic veins drain into the superior mesenteric vein, the SMV.
And the left side drains into the inferior mesenteric vein, the IMV, which usually joins the splenic vein to eventually form the portal system.
Exactly.
And clinically, if you connect this to the patient presentation, that venous anatomy is perfectly unforgiving. It dictates exactly why colon cancer metastasizes primarily to the liver.
Right. It's a direct pipeline.
The entire venous output of the colon is funneled directly into the portal vein and straight into the hepatic sinusoids.
The liver is the very first capillary bed those circulating tumor cells encounter.
It even explains why portal hypertension presents as rectal hemorrhoids.
It does. So when performing a cancer resection, especially now in the era of complete mesocolic excision, or CME, managing that venous outflow is really the very first step of the operation.
How does that actually look in practice?
Take the left side, for example.
What?
High ligation of the IMV right at the inferior border of the pancreas. It isn't just about stopping venous return.
It's an anchor point.
Yes, it is the gateway to the operation. By isolating and taking the IMV high up at the pancreas, you elevate the entire mesocolon, which naturally opens up that avascular embryologic plane we discussed earlier.
Oh, Told's fascia.
Exactly. It provides the upward traction you need to sweep the mesentery off the retroperitoneum from medial to lateral.
And this really brings us to the core philosophy of CME and D3 lymphadenectomies, because this isn't just about taking a wide margin of bowel. Historically, we just clamped the mesentery and took a wedge of tissue and called it a day.
Yeah, the old way.
But CME treats the colonic mesentery as an intact, sealed envelope.
A fascial envelope.
Right.
The mesocolon is covered on both its anterior and posterior aspects by this incredibly thin layer of mesothelial fascia. The lymphatic channels and the lymph nodes are completely contained within that envelope.
Which is key.
Right, because the principle of CME is that you must dissect along the embryologic fusion planes without ever tearing that fascial envelope.
Because the moment you tear into the mesentery during your mobilization, you risk spilling microscopic tumor cells, or tumor-bearing lymphatics, directly into the peritoneal cavity.
And you are instantly turning a localized, curable cancer into peritoneal carcinomatosis.
That's a disaster.
If we connect this to the bigger picture, the precision required is just staggering. You have to take the primary vascular pedicle right at its origin on the aorta or the SMA, dissect out the central nodes, and remove the entire segment of bowel and its intact mesocolic envelope en bloc.
And you really have to know exactly which nodes drain which segment. Like, that's the foundation of precise lymph node mapping.
Exactly. If a tumor is in the transverse colon, its primary drainage might follow the middle colic vessels straight to the SMA route, or it might track along the left colic vessel.
Which means the surgeon has to map the lymphovascular basin in real time, often using preoperative 3D vascular reconstructions just to identify aberrant anatomy before even scrubbing in.
Because the textbooks will tell you the right colic artery is present, but in the OR, you might find it completely absent.
Or arising from a common trunk with the middle colic.
Right. The variations are endless, but the oncologic rules remain completely rigid. You have to capture that entire lymphovascular drainage basin.
Always. Well, as we wrap up this roadmap today, we've covered a lot of ground. We started with the surface landmarks, using Paine to guide us.
Right, and then Told's fascia for safe, bloodless mobilization.
Then we mapped out the SMA and IMA power grids, the watershed danger zones like Griffiths and Sudex points.
And finally, managing the lymphovascular basins for total cancer clearance.
It's a lot to keep track of when you're at the console.
It is, but, as we finish up, there is a concept that always strikes me when looking at the evolution of our field.
Oh, What's that?
Well, think about a modern, state-of-the-art operating room today. You have the surgeon sitting at a robotic console utilizing high-definition 3D optics, near-infrared ICG angiography, advanced ultrasonic energy devices.
It really is the pinnacle of modern technology.
It is, but here's the thing. The technology doesn't change the anatomy.
No, it doesn't.
And that is the paradox here. The exact surgical boundaries you must respect today, the planes you have to follow to avoid bleeding, and the margins you must achieve to actually cure a patient of cancer, they were strictly, rigidly drawn millions of years ago by microscopic embryological development.
That is wild to think about.
Right. The simple rotation and fusion of the midgut and hindgut in a tiny developing fetus in utero is what ultimately dictates the exact boundaries of modern radical cancer surgery and patient survival outcomes in a robotic OR today.
The blueprint was drawn long before we ever picked up a scalpel or, a pair of robotic shears.
Beautifully put.
And understanding the logic of that terrain, how it fused, how it's tethered, and how it's perfused, that is exactly what separates a curative, elegant operation from an anatomical demolition.
Absolutely.
Well, we hope this roadmap serves you well the next time you step up to the table. If you like this content, then do not forget to share with at least one of your colleagues or friends and spread the word. Also, check out our YouTube and other social media pages.
Yes, please do.
And do check our previous season and episodes with some very relevant topics. Thank you for joining us in the deep dive, and we will catch you in the next one.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.